Welcome. In this session, we will explore preterm birth as an adverse event following immunization in pregnancy vaccine safety. Preterm birth is relatively common and can be serious. It is an important cause of illness and death in young children worldwide. We will review what preterm birth is, how common it is, why it happens, and how to identify and classify it using Brighton/GAIA, which is Global Alignment of Immunization Safety Assessment in Pregnancy Case Definition, and the SPEAC Companion Guide. This video is intended for people involved in maternal vaccine trials, post-authorization studies, epidemiological studies, cohort event monitoring, pharmacovigilance, and casualty assessment. Preterm birth is defined as birth of live infant before 37 completed weeks of gestation. That is, before 259 days from the first day of last menstrual period, or LMP. Preterm birth is usually grouped in three standard categories: extremely preterm, or birth before 28 weeks, very preterm, from 28 to less than 32 weeks, and moderate to late preterm, from 32 to less than 37 weeks. These categories are widely used in clinical care and research. Importantly, this definition applies to the live-born infants. Preterm birth is common. The most recent WHO and UNICEF estimates based on 2020 data indicates that about 9.9% of live births globally were preterm, roughly 13.4 million babies in a single year, and that most preterm occurred in Southern Asia and Sub-Saharan Africa, which together accounts for approximately 65% of all preterms worldwide, despite having about 55% of global live births. Preterm birth rates in high-income countries are generally around 5 to 8%, while rates in parts of Sub-Saharan Africa and Southern Asia can reach 12% or higher. Within countries, rates differ according to maternal age, access to antenatal care, multiple pregnancy, infections, and broader social and environmental factors. Preterm birth is best thought of as an outcome with multiple mechanisms, not as a single entity. GAIA and Brighton work describe four main clinical pathways to preterm birth. The first is spontaneous preterm labor, accounting for approximately 40 to 45% preterm births, where contractions and cervical change begins earlier than expected. The second is preterm pre-labor rupture of membranes, or PPROM, responsible for about 25 to 30% of cases, where the membranes rupture before labor starts and before term gestation. The third is cervical insufficiency, where the cervix shortens and opens without contractions. The fourth is provider-initiated preterm birth, sometimes called medically indicated preterm birth, accounting for approximately 30 to 35% of cases, where labor is induced or a cesarean section is performed early because of maternal or fetal indications, such as severe preeclampsia or fetal compromise. Known risk factors for preterm birth include previous preterm birth, multiple gestation, very young, that is less than 20 years of age, or advanced maternal age equal to or more than 35 years, short inter-pregnancy intervals, that is less than 2 years, maternal infections, hypertensive disorders, diabetes, smoking, and low socioeconomic status, among others. A preterm delivery after vaccination must be interpreted in the context of these clinical pathways and risk factors. Clinically, the mother may present with uterine contractions, ruptured membranes, or an induced labor or cesarean section before 37 weeks. For baby, being born preterm means being smaller and less mature, with higher risk of breathing problems, difficulty feeding, infection, and longer hospital stay, especially at lower gestational ages. In data systems, preterm birth is usually identified through a recorded gestational age at birth, such as 34 weeks and 2 days, and or diagnostic terms or codes for preterm birth or prematurity. Importantly, preterm birth is defined by gestational age, not by birth weight alone. To apply preterm birth case definition, we first need to know how gestational age was determined. The Brighton GAIA framework assigns level of diagnostic certainty for gestational age based on these standard methods, which in turn determines how confidently the birth can be classified as preterm. Better gestational age ascertainment supports higher diagnostic certainty. The GAIA case definition describes a hierarchy of gestational age assessment diagnostic certainty using various methods. At top, level 1 is first trimester ultrasound, performed at equal to or less than 13 weeks and 6 days gestation, which is the most accurate method for determining gestational age prenatally, along with having known dates from assisted reproductive technologies such as IUI, that is intrauterine insemination, or embryo transfer, confirmed by a first trimester scan. Level 2 is achieved when certain date of LMP is available, supported by a second trimester scan, that is from 14 weeks to 27 weeks and 6 days, or by first trimester physical examination. An uncertain LMP with a second trimester scan also supports level 2. Level 3 applies when gestational age relies on a third trimester scan, fundal height, newborn physical examination, for example, New Ballard score, and or birth weight with or without a certain LMP. The Brighton GAIA case definition for preterm birth and assessment of gestational age uses level 1, 2, and 3 of diagnostic certainty, built on the certainty of gestational age. Level 1, or definite preterm birth, is used when gestational age is established with high certainty, typically through a first trimester ultrasound, or certain conception dates with a confirmatory first trimester scan, and is clearly documented as less than 37 completed weeks at the birth in medical record. Level 2 or probable preterm birth is used when gestational age is based on less precise but still reasonably reliable information, for example, a certain LMP date with a second trimester ultrasound or an uncertain LMP with a second trimester scan, and the data consistently indicate birth before 37 weeks. Level 3 or possible preterm birth is used when gestational age is inferred mainly from later scans, fundal height, newborn exam, and or birth weight, but the overall information suggests that the birth was preterm. Cases where the information is too limited to say the birth was preterm are classified as level 4. Cases where the data indicates a term gestation fall under level 5 as they are not preterm births. The SPEAC companion guide includes tables, checklists, and pictorial algorithms to help teams move from raw data to a consistent level of diagnostic certainty. How do we use this definition in vaccine safety? In clinical trials and post authorization studies, preterm birth should be clearly pre specified as an outcome and, where relevant, as an adverse event following immunization of interest, with case report forms designed to capture gestational age information needed for Brighton GAIA levels. In randomized controlled trials with a comparison group, preterm birth rates in the vaccinated arm are compared directly with those in the control or comparison group, which is the appropriate comparator in this setting. In observational and epidemiological studies without a concurrent comparison group, standard codes such as ICD, MEDRA, or SNOMED combined with procedural codes and other available clinical information are used to estimate baseline preterm birth rates by region, gestational age band, and other variables. In cohort event monitoring and pharmacovigilance, reports of preterm birth after vaccination are followed up using SPEAC abstraction forms so that cases can be classified by level of certainty and compared with expected numbers. Finally, in causality assessment, these standardized case definition and comparison or background rates allow experts to determine whether the number and pattern of preterm births after vaccination are within the expected range or whether they signal a potential safety concern that needs more investigation. To recap, Preterm birth, defined as live birth before 37 completed weeks, affects about 1 in 10 babies worldwide, with the greatest burden in Southern Asia and Sub Saharan Africa. It has multiple etiological pathways and many known risk factors. Therefore, preterm births will occur in any pregnancy cohort with or without vaccination exposures. Accurate gestational age assessment is the foundation for classification of preterm birth using Brighton GAIA preterm birth case definition. And the SPEAC companion guide provides practical tools to collect and interpret data and to assign levels of diagnostic certainty. Using these tools consistently across clinical trials, observational studies, and pharmacovigilance systems enables us to measure, classify, and compare preterm birth in consistent way and to understand whether vaccines are affecting this important outcome. Preterm birth is common, serious, and measurable, and getting it right is essential for protecting the health of mothers and babies in vaccine programs worldwide.